Right. I see two groups of young people here. The one group, the young, dynamic, beautiful ones. The second group of young people, like Dr. Alex and Dr. Narayan Pati and myself, Dr. Verma, we're all young people, but the only thing is we don't look so young. Anyway, welcome. Dr. Anil P. Das, and Dr. Nina, Dr. C. Joseph, and Dr. Davis Akkara. Thank you for inviting me to receive this award. It's a great honor. Dr. Thomas Chirian, KSOS President. Dr. Verma, thank you for your kind words. He is not only a brilliant ophthalmologist, but also a prolific writer, as some of you know. The senior members, thank you very much. It's a great honor. Now, in the late 80s, I was working in Mettupalayam, a small town in Tamil Nadu, in a mission hospital. I had the honor of speaking in KSOS industry meetings, and I didn't have many friends those days, and Dr. Noel Moniz came out of his way to be friendly with me. He was a wonderful individual, a great surgeon, adored by his family and loved by his friends. My first cataract surgery was ICC. It was in 1974. This was before I did my PG in ophthalmology. Now it is 2024. It's 50 years now. So I have decided to entitle this talk as Half a Century of Ophthalmology, an Exciting Journey. Now, this article, June 2022, ITO carried an article on blindness and the economic burden. 2022, there were 5 million blind people, below 3 by 60 in the better eye, and there were 70 million visually impaired, 6 by 18 or less. Now, net loss of GNI, gross national income, was at that time 845 billion. Yes, you heard it right, it's billion. That is in 2022. Cumulative loss because of the backlog was 11,778 billion rupees. Well, let's go back a little. And then this article says in 1986 there were 12 million blind below 6 by 60. And the economic loss, rough calculation by myself, was 1,200 billion rupees. Going further back into the 70s, in the early 70s I was working in a mission hospital in Punjab as a young doctor. At that time there were 15 million blind people in the country. The economic loss for the country was obviously massive. Now, people in the mission hospital challenged me to take up ophthalmology. As the eye surgeon there, decided to resign and go to US. I thought and prayed about it, and I had a spiritual experience. This may resonate with those of you who are spiritually oriented. Jesus seemed to tell me, I am the light of the world. I hate to see people walking in darkness. So I decided to be part of God's answer to the humongous problem of blindness in the country. My contribution would be a teeny fraction of the solution. However, I decided to reach the unreached blind 1976 onwards. So based in Punjab, reached Himachal Pradesh, Jammu and Kashmir, Uttar Pradesh, and 1985 I came down to Tamil Nadu and Karnataka. Punjab we conducted mobile hospitals in villages just before and after the severe winter months every year. The winter months is December and January, so that is just before that. That was October, September, and so on, November, and February, March, etc. In Punjab, there were 3 problems: trachoma, cataract, glaucoma, refractive errors, of course. And in Himachal Pradesh, it's beautiful. Did mobile hospitals during summer. That was April, May, June, July, etc. And also in Kashmir. In Himachal Pradesh, cataract, lesser trachoma, and glaucoma. In Himachal Pradesh, I met Tibetans. You know, in 1959, China had invaded Tibet, and Dalai Lama, the king and the religious head, fled Tibet and came to India. Pandit Jawaharlal Nehru was the prime minister at that time. They gave land in Dharamsala and Kulu Manali in Himachal Pradesh, and also in Karnataka, and that is Bailakuppe, Hunsur, and so on. And he gave them permission to start a government in exile, and based capital being Dharamsala. There are about 1 lakh Tibetan refugees in India. Now, many died on the way when they were fleeing from Tibet because of Chinese invasion, and many died on the way. I started out work in Dharamsala, started the hospital there, the eye department in Delek Hospital, Dharamsala, and also after coming back to the south in Bailakuppe, Hunsur, Kolego. Trained Tibetan nurses and who would look after the patients between my visits. One thing about Tibetans is that no diabetes. That's because they don't take sugar. They don't put sugar in tea. They put salt and butter. So no diabetes, but then there was hypertension even in young people. And they will not hurt animals. And you know, if there is a fly, makeshift theatre, I say there's a fly, go and kill it. So they will go, run after it, and with cupped hands, they will catch the fly, run out of the theatre and release it to freedom. But then there was a dichotomy because they cannot eat a single item of food without non-veg. Even vegetable, you will have slices of beef. So I told them, see, there is a dichotomy here. Now you say that you are purely, you know, unhurting and you don't hurt any animals, but then you cannot eat a single meal without non-veg. She said, yeah, that's true, what to do. Dr. Saab is very cold in Tibet, so we cannot manage without non-veg. But anyway, they're very good people. Jammu and Kashmir work there in summer, not so much as in Himachal Pradesh. Jammu and Kashmir, a bit like Punjab. Jammu was a bit like Punjab. Kashmir, no trachoma. But then, you know, they all have long, beautiful nose, the nose of Indira Gandhi. But many of them have blocked nasolacrimal duct and chronic decrocystitis. Anybody go and press near the campus, you will get puff down here. Now, in Uttar Pradesh, I found real poverty. I conducted ICAMs in Etah, Etawah, Karhal, Mainpuri, Mainpur, Kannauj, Fatehpur, etc., etc. And these were seats of dacoits, kings and queens. I don't know whether you've heard of Phulan Devi and Mokan Singh. And it was dirty, dusty, congested. One day we were driving past and I saw a cake there on the shop. And I said, wow, here in this village, in UP, you have cake somebody bakes. He said, Dr. Saab, it's not cake. It is a stack of chapatis covered by flies. They could spit anywhere, even in a cinema theatre and operation theatre. So operation, I had a tough time saying, please don't spit inside the theatre. We are operating. I had a tough time. I have operated on relatives of notorious dacoits like Phulan Devi and Mokan Singh. This is from Sholay movie, by the way, it's not Mokan Singh. In Uttar Pradesh, there was trachoma, cataract, and glaucoma. A word about trachoma, many of you haven't seen trachoma, have you? Because you are in Kerala, you don't have trachoma here. Very, very rarely you will find trachoma here. You see, trachoma, you have pannus, follicles, ulceline, trichiasis, etc. Now, pannus is the, you can point out here, right? Here, these blood vessels coming from top, superiorly only. So in Punjab, when I was working there, anybody in the street, come here, look and put him on the slit lamp, you will find a pannus there. It was so rampant. Then there are follicles, then the tarsal plate gets scarred up and you will get what is called an ulceline, and you have trochanter, there's syntropion, there is opacification of the whole of the cornea with vascularization, and this is simulifron. These photographs are not mine, they are Google search ones. Now, there are difference between follicles and papillae. Now, follicles are accumulation of WBCs. This is for the sake of PGs who are here. An accumulation of WBCs. They have a pale surface, no blood, central blood vessels. Whereas in papillae, you have a central blood vessels coming like that, and then it branches like a tree. Papillae, raised areas of inflammation, central blood vessel is there, red on the surface, giant papillary conjunctivitis. So you have follicles here, this is not trachomatis, it's viral, and you have here, you will find it is not red, it's pale, and the blood vessels are around it. Now, follicles in trachoma, it can happen in the limbus. Once it gets scarred up, you get the appearance of pits, that's called Herbert's pits. What about glaucoma? No anti-glaucoma drugs were available except Pilocarb in those days. In the early 80s, Timolol became available in one shop in Delhi and costed 120 rupees, and that was an enormous amount at that time. So the best and the only option was trabeculectomy. The results were good, as they were fresh cases untouched by glaucoma medications. In every camp I used to do about 7 or 8 trabeculectomies, and in Umaidpur, a particular camp, first time when we did, I had to do 19 trabeculectomies. Now, huge numbers were handled in eye camps those days. I am biased about this trabeculectomy. I believe that even now, I think that when you diagnose glaucoma, to trap and don't put them on other things. So of course I can't practice it because nobody else would agree with it. Anyway, huge numbers were handled in eye camps those days. Eye camps in the 70s, photos are provided by Dr. Nitin Batra, HOD in CMC Ludhiana now. Now this is a kind of eye camp. You go to a school and convert the rooms as consultation room, treatment room, etc., fraction. And the best room is the principal's room, and that is converted into a operation theatre after cleaning and whitewashing. If there is a hospital there, we wouldn't go there because hospital theatre would be very dirty because they do all sorts of operations there, IMB and all that. So we would rather have a school where there are no particular infections. Now, we had a lot of eye camps in those days. There were two major concerns. Neglect of preventable blindness. Because they were cataract detection camps. They would say, this is immature, come next year. This is mature, come this side. This is immature, go away. This is early, go away. That's all. But, so then trachoma and glaucoma were not treated. Second thing that I noted was many curable blind were converted into incurable blindness because of postoperative complications. What about cataract? Cataract history from these two articles, I get the information. 600 BC, ECC was done by Susruta in our country. Brilliant. He punctured the limbus, went into the anterior chamber, tickled the capsule, and then the nucleus popped into the anterior chamber. At that time, he increased the incision and asked the patient to do Vasarva maneuver, and when the Vasarva maneuver happened, it will come out. Nucleus and cortex and everything came out. That was brilliant, I thought. Anyway, in 5th century BC, the first couching was documented in France and later practiced in India. Sushrita man was forgotten and the ECC for a long, long time. 1749, Jacques Daviel, a French surgeon, is considered the father of modern cataract surgery. ECC was done, 10 mm incision, punctured the capsule, removed the nucleus with spatula and curette. Then came the era of intracapsular cataract surgery. That was 1753, Dr. Samuel Sharp did the first documented ICC using thumb. and fracturing the zonulus. In 1957, Jackman Barker used alpha-chymotrypsin to lyse the zonulus. I used to use this for younger patients. Have you used, Dr. Varma? Yes, you've used, Alex? Yeah. Senior Bazar alpha-chymotrypsin. It's called zonulysin. So inject zonulysin into the posterior chamber, all the zonules get lysed and you can take it out very easily. Otherwise, young people it used to rupture when I was trying to take it out. In the late 70s, most of the instruments that were used all over the world was one graphene knife, capsule forceps, cryo and erisific. This is graphene knife for 180 limbus to limbus incision for ICC. When I tried it, as I punctured the nucleus, punctured the limbus, end of the anterior iris will come forward and you cannot proceed. Again and again I tried, 3-4 times I could not try. I told my seniors that I can't manage. He came and held my hand and said, this is the way you should do it, the way you press and where you pierce and all that. Then you go inside, 3 o'clock, 9 o'clock, it comes out, and then we use one of the instruments that I'm going to just say, capsule forceps. Capsule forceps is a tremendous instrument, and you catch the capsule out here at 6 o'clock and then pull it, and then out it comes. And by the way, this capsule forceps is a wonderful instrument if you have hyphema to take out the clot. It can just pull it out very easily. Now, second was cryoprobe. The cryoprobe was a wonderful instrument. You retract the iris, you touch the capsule, and the cold penetrates onto the cortex and to the nucleus, so then the cold penetrates right down. So it is a capsulocortico-nuclear pull, a very strong pull. It doesn't rupture. Whereas when you hold it with capsule and take it out and rupture, then you'll say, Doctor Saab, bad surgery, it has become extra ho gaya. Right. The other one was erisific for Morgagnon cataract. Erisific, you touch the capsule and there is suction, you release the bulb there, and because of suction it gets caught and then it comes. But most of the country at that time, no magnification, no gloves, limbal 180 degrees, no sutures, ICC. This is a kind of a camp surgery, a torch without magnification. So I witnessed a lot of incurably blind turned into incurably blind category in cases done in eye camps. So because of post-operative complications like wound leak, iris prolapse, choroidal detachment, shallow AC, shifting glaucoma, endophthalmitis. Endophthalmitis was rare. It's surprising. Senior surgeons will understand what I'm saying. Dr. Victor Rambo, he was a professor of ophthalmology in CMC a long ago. And he's a wonderful gentleman. He did a lot of work in North India especially. He said, raise the standard of the eye camps. Don't have eye camps, have mobile eye hospitals. This is Dr. Rambo with Dr. Arun Chatterjee, who was my own professor in Ludhiana. Dr. Vettat, I don't know whether you remember. Yours? Yes, right. So we carried Hackstride, slit lamp, autoclave, operating tables to remote parts of North India. Those days, we are talking about late 70s, even medical colleges at that time didn't have a decent slit lamp. There was a joke about Amritsar Medical College. The head of the department had the slit lamp, and he used to have only he had the permission to look through the slit lamp. So Dr. Dalit Singh, who was not the head, was not allowed to touch. So he made one slit lamp. So at that time, but I could do applanation, gonioscopy and all that. And those days, fundus used to be seen by ruby lens, started with H in the remote parts. There was an eye camp in a village in 1982, just outside the theatre. So I don't know whether you can recognize me on the theatre clothes. Mobile eye hospital theatres like this for illumination, car headlights were used because we wanted to improve on the illumination. And there were 4 operating tables, One for the surgeon, the other 3 for blocking, draping, padding after the surgery. No second was wasted. And it moves fast. Of course, there was no NABS those days. Zeiss loops were used for magnification. Well, SCC was done all over the world, that was the accepted method. But then we found that in the West there were not many complications because they were using multiple corneoscleral sutures. And that's the way to reduce postoperative complications to a substantial degree. So we decided to do with multiple corneoscleral sutures. It was expensive, but decided to do just that. It was all very well in Punjab. We used to enjoy the camps and all that kind of thing till around 1983, Bindrawali started his Khalistan movement and terrorism became the norm. So it was very difficult to have eye camps when these terrorists were around. And if you don't have a turban, they would come and shoot. And later, oh, I didn't mean to shoot you, you're a Christian, aren't you? They were against Hindus, not Christians. But then they shoot, and after that thick. Indira Gandhi was ordered Operation Blue Star in June 1984, and he paid for it. She was assassinated in October 84. I was there all those days. Then I shifted to Metropolitan in 1985 because I could not do any of the jobs that I was doing at that time. Now, ECC comes back after about 200 years. In early 80s, when majority of surgeons still thought ICC was the best way, a few surgeons like Dr. Daljit Singh shifted to ECC. Another person was Dr. Om Prakash, who was the father of Dr. Rohit Om Prakash in Amritsar, and some other surgeons. Daljit was an amazing surgeon. I watched him in Amritsar and was inspired to do ECC and IOL implantation. 1985 onwards, and when I was in Metropolitan, I started doing regularly. A lot of objections from patients till they started seeing the result. They said, "Lensa, kan ulla podradha, adala vedam." Just pore eduthinga, avladha. Those of you who don't know Tamil, apologize. 1985 onwards, I tried various types of IOL implantation: ECC, PC IOL, regular, AC IOL, and retropupillary iris claw. I think I was the first in the world to do retropupillary fixation of iris claw. But there's no documentation, so the world wouldn't accept it. Dr. P. N. Mohan visited me that year, or 86, I don't remember, and asked me to write an article for a KSOL journal. So I wrote an article, Experience with the First 500 IOLs. Now, late 80s, there was a acute shortage of sutures. So Dr. Krishnan Kuti in Thrissur was making sutures out of 30 gauge needle bent brilliant. So that was a relief. But then I was desperately trying, there must be a technique in which you can do sutureless surgery. Dr. Michael Blumenthal came up with the idea of sutureless SICs. Dr. Ravi Thomas popularized it, and a few others. And at that time, independently, I also took it up in Metropolitan and trained. I had to train myself. There was no coach, no internet, but CDs were available. Did a large volume of SICS IOL surgery. In the late 90s, shifted to phaco also, and then back to SICS. See, the major problem in manual SICS is astigmatism. Worked hard to find an answer. My struggle with astigmatism in manual SICS. So they said it's because of the length of the incision. I was doing superior incision, so tried to shrink the length to 3 millimeters. And I found a substantial reduction in SICS, in astigmatism. So this is the it's not working. Video is not working anyway. It's working? Alright. So that's how you take it out. There's a 3 millimeter incision and back cut. So some people say just 3 millimeters with the back cuts, the length is maybe 6 millimeters, but the point is that the astigmatism came down. So in Drishti, I think about 12 years ago, Dr. Jason, I think, told me, why don't you shift to temporal incision? From that, I changed to temporal incision, and I was pleasantly surprised. SI, surgically induced medicine, came down to less than 0.5 diopters. Never went back to superior incision except for cancer to cancer, more than 2 diopters of withdrawal astigmatism. So to reduce surgically induced astigmatism SICS, you have to have temporal tunnel incision, no irregularity in external or internal incision, half thickness, uniform, single plane tunnel, minimized length, closest point 1 millimeter outside the limbus. Objection number 2. Temporal SICS means the wound is exposed, increased chance of post-op endophthalmitis. The answer is a transconjunctival incision with a mini flap. So you find here there is an incision. This works like a mini flap which will cover the incision, and so that way you can manage. Now, cases where manual SICS is certainly a better technique than phaco, subtotal, like a subtotal subluxation, significant pseudo-exfoliation after acute angle closure attack. This morning there was a presentation of a brilliant technique of that, but without posterior vitreous aspiration. I feel that SIC is a technique for that. Like phacolytic glaucoma, subtotals, and so you find, so this kind of case where there is, the zonules are not there most of the time, parts, and then this kind of thing, if I try phaco, I don't know, phaco surgeons would do phaco in a case like this, but SICS is, you have better control, you'll be able to do that and put an iris claw lens. So it has been an exciting journey, and 50 years, never a dull moment. It was tough, it was difficult, sleepless nights. And SICS does not mean that lack of equipment. You have the best equipment to calculate and best of everything. But of course, if people want phaco these days, so my son Ashish does 80% phaco, and I still stick on to SICS. My family says hi to you. Thank you for your attention.
Thank you so much, Dr. Kuruvilla. Half a century of ophthalmology, an exciting and wonderful journey indeed. And it was indeed the history of ophthalmology in a nutshell, especially to the PGs.